Okie dokes, welcome to the first Monday of 2025 and our first Menopause Mondays for 2025. Natalie and I are so pumped that we were able to take this into 2025 and we look forward to this journey continuing. So today we have an amazing guest, Dr. Mark Hoosang. And I'm just going to do a quick intro, Mark, and then what we're going to do is just jump straight into questions because Nats has ever so kindly come up with a lot of amazing questions. I don't want to waste, I want to really jump into our questions. So, Dr. Hosang is a highly experienced cardiologist at the Heart, Lung, and Specialist Center, specializing in cardiac stress imaging. After completing your undergraduate medical and general internal medicine degree at UA, you pursued further specialization in general cardiology at University of Toronto, followed by fellowship in stress imaging, focusing on stress echocardiography and nuclear stress testing, which I think is fantastic. With your medical career spanning over 2 decades, you don't look like you should have been doing medicine for 2 decades, Dr. Holmes. You look
I
very
know, right?
young.
Class of 1999, so
Woo! Fabulous,
that's
including more than 15 years in cardiology, which I think is amazing. You offer a wide range of services, including cardiology consultations, ECGs, echocardiograms, stress testing, whole-term monitoring, and of course, ambulatory BP monitoring. So welcome, Dr. Hosang. It was a long bio, but let's get started. Welcome.
thank you, Nikki, and thank you, Natalie, for inviting me to be here. I really appreciate the honor to be a part of this project because I think it's something that's very important and really trying to improve the health of our people is so important, and hopefully it will go even beyond Jamaica. Maybe
It
it even
does.
has. I'm not even
It
sure, but
has. This
but
goes to
Yeah,
Trinidad, Canada,
ah, ah,
Germany, all over. We have
well,
women
there you
from
go.
all over.
we're
It's
worldwide. We're worldwide.
That's right,
And
amazing.
international.
what you do is so important. I mean, you've helped my family out in the past. I concur with Nikki. You don't look like you can have the amount of experience that you have, but good genes. Um,
Thanks.
one thing that we find curious is that women, you know, traditionally when we think about heart disease and heart attacks, we tend to always think that it's men, and but we're
Mhm.
seeing more and more where heart related conditions is a significant part of a woman's life now, and even more so in menopause. Why is that?
Well, well, Natalie, it has a lot to do with the changes that occur. And I think what our current thinking right now is that estrogen is probably one of the biggest players in the game. And usually, I suppose why we think of it more as being a man's disease is because usually when women are within the reproductive age, they have higher levels of estrogen. And it's thought that estrogen is actually protective for heart disease. So when menopause comes along and then there's a fall in your estrogen levels, it's these protective effects actually go away, and
Okay.
the woman's risk actually now rises to that of a man. So after menopause, the risk for all women is the same as any man, which is quite significant because of the fall in the estrogen. And more recently, there's data to suggest that one of the other hormones called FSH, or follicle stimulating hormone, may also be involved with a rise in the FSH occurring even earlier than your estrogen starts to fall as you approach menopause. So it seems to be a hormonal effect. And most of the data, I suppose, has been focused on the role of estrogen in the process.
Right. So that was really interesting what you said about estrogen being heart protective. So, does that mean that a perimenopausal woman is also at risk? Not just, we define menopause as 12 months have passed and we haven't had a period, right? Um, but in that perimenopausal place, hormones are starting to fluctuate. So, does the
Absolutely.
risk start at that point that we're in perimenopause?
Absolutely. So I think that the risk is starting to occur as you go into that perimenopausal period. because that's, as you said, as you rightfully said, that's when your hormones are all fluctuating. Because for most people, menopause will occur somewhere between 45 to 55 years of age. And during that period, because of the fluctuations, you do start to see some of the effects of these fluctuations. Because estrogen is produced mainly by the reproductive organs, the ovaries, and the placenta. But it can also be produced by other organs like muscle and bone and brain and even the liver. So the estrogen is thought to be protective because it has functions on your cholesterol levels. It has an effect on your blood pressure lowering. It even acts on the actual endothelium. So the endothelium is actually that little layer that's lining your blood vessels. And it's more than just a layer because it's actually very active, and it is responsible for what we call dilation, which is opening up or closing off, which is a part of the control of blood pressure. So there are a lot of actions that start to occur. So as women go through this perimenopausal period, these things are what we will call risk factors, like increasing risk of hypertension, changing cholesterol levels. So the LDL, which is your bad, what we call the bad cholesterol, starts to go up, and your HDL, which is the good cholesterol, starts to go down, as well as other things like your sugar starts also as it tends to go up. So it increases the risk of all these risks, increases the risk of these factors, which is now the beginning of that process, because it's not like, you get menopause and boom, that's it. Your risk is the same. It's a continuum as things change. It's a spectrum as you go from the different levels and the consistent normal patterns of your estrogen release to now the menopausal type levels. So yes, during the perimenopausal period, there is a slight increase in risk, but really that's just the beginning, and we're probably not going to see the effects of this until a few years down the line.
That is
That's really
scary.
interesting, eh? Yeah, it
It's
is,
actually
because
quite scary, Natalie, if you think about it.
what this means then is that, I myself, I'm like, I eat well, I exercise, right? And then all of a sudden they're telling me that my blood pressure is going up and my cholesterol is going up, right? And this is with no changes to diet and lifestyle. So diet and
Right.
exercise are, so is it a true, if it is that it's that the heart protective or the risk factor protective function of the estrogen is starting to go away, so things are starting to come up, like these risk factors, the cholesterol, the blood pressure are creeping up. Is it safe to say it's a real, because if you're young and healthy and get
Mhm.
high blood pressure, high cholesterol, we know it's a risk factor. So
Right.
it's a real risk factor. Like, it's
It
not
is.
just to say, oh, it's just my estrogen is falling and that's why the numbers are changing. It's a real risk factor.
Right. So all those things are true. So your estrogen is falling, your numbers are rising. And as a result of the rise in the numbers, it means that your risk also rises. Because when your blood pressure is higher, it puts more strain on the different organs. It puts strain on your heart. It causes damage to different blood vessels, to different organs, which is why risk of things like heart attacks and strokes go up, because there's damage to the actual blood vessel. Um,
Right.
yeah. So, but I mean, what you're doing is probably the greatest thing that you can do in terms of your diet and exercise. Because it's something that, as doctors, we talk a lot about medications, but really your diet and your exercise are very big parts of maintenance of health. Because not only do you have to worry about things like hypertension and diabetes and high cholesterol, but other things like osteoporosis, because osteoporosis is a big part of the aging process. Um,
Mm-hmm.
and as your bones get weaker, sometimes you're more at risk of falls and injuries, which will interfere with your whole exercise pattern. And we know that exercise is needed for heart health.
Yeah, I see where you're going with this. I see where you're
Yeah.
going with this. Because we did interview Dr. Lofters and Sasha Chung before the year ended, where we spoke about bone and stuff. But I see where you're going with this. That if you're cautious about breaking bones, you might not be exercising as much, and then you get into that vicious cycle. Wow. Sorry,
Yeah,
Vicky,
you
you
know,
sounded like
no,
you.
Having a broken bone before will also, or weak bones, you might be concerned about it. So those
Right.
things are important. So the resistance training is a big factor
Mhm.
in reducing that risk.
Yeah, no, I was saying that. So we were talking about your cholesterol and whatnot. For me, Dr. Hosang, it was my telltale sign of me going into menopause is that I went from having very low blood pressure. I've always had low blood pressure to all of a sudden I was 160 over, I don't know, 90 or 80 to the point where I had to go on blood pressure medication. And I, like Natalie, exercise, I eat well, I'm, all of these gluten-free, dairy-free, all of these things, I exercise. So I think for women, it's so important that if you see your numbers changing,
Right.
that you address it quickly. So the cholesterol, the blood pressure, all of those things, I think it's super important that if you see your numbers changing,
For sure.
it's not your norm and you're kind of doing the same thing that
Mm-hmm.
you have. But my question is, we talk about diet and exercise, but we also talk about medication and we say HRT and stuff like that. For the women who can't take HRT and they're doing their diet and exercise, obviously medication is going to be their only avenue at this point, whether it's blood pressure medication or cholesterol medication. Is there any disadvantage to it then, if you will? If some women don't want to do that, they don't want to do the cholesterol and the blood pressure medication, what can they do?
Um, well, I think I think like most answers, it depends. And it depends on the individual. And I think we need to go back to Natalie's first question about the perimenopausal period and how important this is, because that's when the changes start to happen, and which is where I think that is the point where really close monitoring is what is required, because we know that things are going to change or have a higher chance of changing. So I think that period is probably the time where it's good to really encourage women to have closer monitoring by their doctors, their general physicians, to have a look at their blood pressure, their cholesterol levels, and their sugar. Um, and we know that many people are somewhat reluctant to go on medication, and but sometimes it's necessary, and it becomes necessary based on what we would perceive based on our current medical knowledge as your level of risk. So things like when to initiate cholesterol medication, for example. So there's no one number that we would choose for that, because we would address someone who is 20 years old different from someone who is 60 years old, because your age is factored into that risk calculation.
Makes
Because
sense.
we'd be willing to accept more of a higher number from a younger person, but from an older person, especially if they have other risk factors. So if you have hypertension, your risk would be a certain thing. If you have hypertension and diabetes, then that's a
Mm-hmm.
whole other
Mm.
level of risk. So as you get higher and your risk goes up, then how we think about these different patients will also vary. And the more risk factors that you have will be the most likely reason for us to start medication. And sometimes it is necessary, but before that, and really even before the perimenopausal period, and probably going back to childhood, I think we need to look at lifestyle, and in what we're eating from we're young, from we're toddlers, from we're going to primary level school. And I think that's very important in terms of looking at, because there's something what we call a legacy effect. So a lot of these things that you start doing in childhood, they carry out throughout life, because what they've seen is that even in some
Mm-hmm.
children who are overweight and whatever, they can actually detect evidence of changes in the blood vessel, almost like beginnings of atherosclerosis, or hardening of the blood vessels from earlier on, and a lot of that has to do with their lifestyle. Um, so, if you're going to wait until you're 40 or 50, then you may be missing the boat.
Mhm.
Yeah, welcome to our song sheet. Like, this is something that we talk about all the time too, is that not to wait until this stage, and it's like, sidebar, deeply concerning, because so many young people are video gaming, cell phone using, and we don't see them running up and down, kicking the rock stone in the, the park anymore, because there ain't no more park, right? So we
Very
really
true.
have to make a active, and I know I'm guilty. Like I have to make an active, concerted effort to say, "Come, we're gonna go for a walk. Come, we're gonna go for a hike. Let's get off the couch and go outside." But that's really scary. I was wondering. Well, one thing I wanted to say is that I fully agree that if your doctor says, in Jamaica we have this natural perspective on a lot of things. I want to be a naturalist or whatever. But if your doctor is telling you clearly that you are at risk of something, I think it's really in your best interest to listen to your doctor, right? Before it gets to that level, though, if you're still in that negotiation phase, because us patients love to have those
Right. No, I
negotiations,
get it. I get it.
there are definitely supplements that can help with some of these risk factors, right? So, for example, L-arginine is a fantastic amino acid that converts to nitric oxide and helps to dilate the blood vessels. So that helps to reduce blood pressure. And then there's other botanicals that you can get in single or you can get in combination. Like we have something here at the Life Store called Blood Pressure Wellness, and it really helps people. I find if you couple that with giving up alcohol, which that's a whole different topic for a whole different, but alcohol
We
is
need two shows for that.
alcohol is, no matter which way you want to cut it, dice it, slice it, it is poison, right? And it destroys your cardiac cells and it sends up your blood pressure and it puts pressure on the heart. So things like that. And then when we're looking at cholesterol as a risk factor, there is something called red yeast rice, which is
Yeah,
excellent at
yeah,
helping to
it
bring
is.
down
Yeah, for sure.
cholesterol. So we can start with some of the natural things, but if the natural things get to a point where they're not working and your doctor is saying, look, it's this medication or you have gonna have a problem, I really think we need to encourage people to listen to
Yeah.
their
Oh,
doctors for
for sure,
sure.
Natalie. I agree with you 100%. And as you said, there is that in-between negotiation phase, which I do a lot with my patients. And there's always room to bargain, a little bit of room. And
Yeah.
yeah, and during that period, so sometimes we'll say, okay, well, we notice the blood pressure is inching up. We notice like the sugar is inching up. And I'll say, well, you need to make certain lifestyle changes. And that includes both your diet as well as your exercise. And some of them
Yeah.
will say, well, go to these other things like the red yeast rice and whatever. And I say, well, yeah, for sure. Go ahead. Let's do this. Let's see what happens. Let's give you 3 months, 6 months to see how you can get your exercise program going on. Have you started your walking? What's happening? And let's measure these things because these are
Hmm.
things that we can measure.
Yeah.
Right.
So,
Yeah.
to be scientist, sure, go ahead, take the arginine and the red rice yeast, and go ahead and let's see what happens. And if you can get back to where we would be comfortable seeing some of those numbers and parameters, then for sure, we
Hmm.
can for sure delay going on medications. But
Yeah.
there has to
Okay.
be a change and there has to be consistency, which I think is the greatest.
Yes. Right. 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 Nikki, it looks like Tanya has a question or a
Y-
comment.
yes. Yes. Unmute, Tan. Go ahead.
Happy New Year to everyone.
Happy New Year, Tana.
Yeah.
Mark, fancy seeing you here.
I know, right?
So, sorry, I joined late. I was running up and down trying to get back to this meeting. But since the conversation of menopause has become so topical, I'm one of those doctors who doesn't mind when their patients come with questions. I know some doctors don't like that, but that's what keeps us on our toes. What I would encourage patients to do, however, because you heard Mark talk about the risk calculation, because it's not just about numbers anymore. It's about the whole picture and how those numbers, including your blood pressure, your cholesterol, your weight, etc., are going to contribute to those adverse outcomes that we're talking about, the stroke, the heart attack, etc. So what I would love for patients to do is to become more aware of that concept. And if your doctor is just writing prescription, and there's no discussion with you about your risk score, bring it up with your doctor, okay? Because a certain number may look okay, but in the like you get, everybody wants a female executive and it comes back and everything is normal. or what they think is normal, it has to be looked at in the context of your other comorbidities. For instance, if you have diabetes, that's a whole different ballgame in terms of the numbers. So it will look normal on the panel, and a lot of patients ask for their copies, and everything is all in the in range. But when you look at the numbers in conjunction with the other things we have to look at, it may actually be higher than we want it to be. So I'd encourage patients to become more empowered. I know that there are, and one of the discussions I always have with the cardiologist is, which tool do I use, right? Because some of the tools are not for our population, which is mostly Black. They're done in studies of mostly white people, which don't apply to us, for the most part.
Yeah.
I know the WHO has made a very simple one, because the truth and the fact is lab tests are very expensive. And we can't wait
Right.
on lab tests to make a decision. So WHO has a very useful tool. It's actually a PDF you can print out, where even if the patient hasn't done any tests, just their BMI, their presence or absence of diabetes, etc., can give you an approximation of that risk score. So it's something that I want patients to really have a conversation with their doctors about, because a lot of people don't understand that it's just about, oh, I just need to refill my prescription, everything looks great. And the next thing you know, they have a heart attack, and everybody's like, how come?
Right.
So that's
Right.
really what I wanted to bring across.
Thank you
Tana,
so
when
much.
you talk about those risk factors, or Mark, what do you think about the waist to hip ratio or waist to chest ratio as markers?
Right. So the thing is, the truth is, also the tools don't have that. I haven't seen any tool yet. Mark, have you seen any with waist
I
circumference
don't
and hip
recall seeing a
ratio?
tool with that. No.
Right. So it doesn't really take that into account. Yes, we know BMI is not a foolproof method, but it gives you a starting point.
Mhm.
What it can indicate your waist circumference is whether you're at risk for things like metabolic syndrome, which then also puts you at higher risk for developing comorbidities that you don't already have, or then the adverse outcomes as well. So yes, the waist hip ratio is useful, but in terms of plugging it into our risk calculator, I don't think we're there yet. So
Okay.
we have to use what we have, and at least, and in my mind, a lot of times when you do the risk calculation, sometimes I find it's an underestimate, but it gives you a baseline to say, okay, it probably is higher than this, so we need to have a conversation about what can we do to decrease your risk over time. And I'm glad you told me about the L-arginine, because I'm actually doing some reading on it now, because a lot of complementary alternative medicine, that's what we grew up on. From your grandmother give you bush tea and ginger, you're doing complementary alternative medicine.
Exactly.
And that's the truth, right? So we have to be able to have a discussion with our patients about what they think might be working, but within reason. Because one of the problems with red yeast rice that I found is, what is the standard dose? You come
Mhm.
with so many doses, and you're like, I don't know how much you tell this patient to take, because nobody really knows, I've had
Yeah.
patients, and I mean, in people in my family who were against the statins and so on. So they wanted to try the red yeast rice. It never worked for them. So you have to find the patients that it works for, but you give it a trial period. It's not forever and ever, amen. It's okay, let's try this over a couple of months, let's reassess you, and then let's have a different conversation at that point. Because one of the problems we have sometimes is it's clinician and patient inertia. We just get stuck at one point and we don't move. And that's not helping the patient at all. Okay.
Yeah.
Sure,
Yeah.
very
Yeah.
good points, Tana. And it's just to emphasize that this is a dynamic process. And it's not that you just use one number or one measurement at one point in time and you say, well, that's it. But we make changes, and we can measure these changes, and actually having proper follow-up is very important
Right.
to determine the direction in which we go. And I found Natalie's question very, very interesting, because she spoke about waist circumference and hip to waist ratio, which is interesting, because here we're talking about menopause, and that's one of the things that actually changes during menopause, because you actually develop more central fat as
Adiposity. Yeah.
and adiposity, which we know is a higher risk. I mean, there's tons of data out there to show that is a higher risk for heart disease and cardiovascular disease.
Right.
Because you have more what we call visceral fats. There's more fat around the organs, which is now more metabolically active, creating more inflammatory markers. So we don't have a score for it, for sure, but we know that it is associated with an increased risk.
Right, right, right. And then, so you actually answered one of the questions that we had, which was, the weight gain that comes with menopause, if
Yeah,
that is something that's also going to change heart risk factors. And what I'm
yes.
hearing from you is yes.
The answer is yes,
Mhm.
yeah.
There's also, as your hormones fluctuate, your irritability increases. Um, and then also perhaps your stress levels
Oh,
increase as well. So your cortisol is going up. These are also going to lead towards heart related concerns, right?
right. No, for sure. So as you said, I mean, you become more irritable and probably your usual ability to cope with stress becomes impaired as a result of the hormonal shifts. And we know that when an organism is stressed, there's an increased cortisol. An increased cortisol is associated again with higher blood pressures and changes in your cholesterol levels, as well as your sugar levels. So if it's just stress for one time, then that's not a big deal. But if it's over a longer period of time, the chronic or long-term effects of that will have other detrimental effects.
Right.
Impairment of sleep will also start to occur because of increased stress. Because
Mm-hmm.
as we all go through, whenever we're stressed for whatever reason, our sleep tends not to be as good. So the more stressed we are, the worse our sleep is.
Mhm.
And we know that sleep is very important for overall health and
Yep.
cardiovascular health as well.
And there's a point that Mark brought up, which I'm very passionate about, follow-up. And a lot of our colleagues are guilty of this, that they kind of give the patient a prescription. And so when the prescription finish, come back. Truth is that they may have gone to 2 or 3 other doctors and got the same prescription. So they have a prescription for a year. And yet they don't see their primary care physician in a year because they were told, come back when your prescription finish. Now, the standard of care dictates that if you have a chronic illness, you're supposed to be seen by your doctor as often as your control will dictate. So it may be somebody who is constantly uncontrolled. You can't be seeing that patient every 6 months. You're not doing the patient any good. So again, for patients to be proactive before you leave your doctor's office, before they say, all right, they don't say anything to you about a follow-up. Or they say, come back when your prescription finished. Said, okay, how about me coming back in X number of months? So really and truly, a lot of the guidelines you see say every 3 to 4 months. And uh, if it is that the control is good, great, that's fine. But if the person is uncontrolled consistently, 3, 4 months is 3, 4 months of battering of all the organs and tissues, including your heart and
Right.
your brain.
Mhm.
Nobody
Mhm.
wants that. Nobody wants to get beat up every day for 3 months. So it should be something that is a discussion. And kind of force your hand sometimes with the doctor to say, hey, but I think I should be seen a bit more often than that because my blood pressure is not under control and I'm concerned.
Yeah,
Don't
Yeah.
keep it to the physician alone. It is a partnership. We are here
absolutely.
to guide and steer you in the direction of what we know to be standard of care in the context of patients' preferences. But at the end of the day, the patient really is the one who has a lot of the choice to say, can we have a discussion about this?
Mhm.
Okay.
Yeah, no, definitely, Tana. And I mean, we're the ones who know our bodies. The doctors don't. So I mean, we're the one. The onus is on
That's
us
it.
to share as much as we can, go as often as we can, because we're the ones with the information. Let's switch gears a little bit and talk about screening and early detection, because I think
Wait,
this is going to
Nikki,
be, yes, babe.
before you switch gears, and I want you to come right back, but I think what just came up is super important. There is aside from making sure that you're seeing your doctor often, there is a condition referred to as polypharmacology, right? And this kills people, right? So basically, what you have here is you have Dr. A writing a prescription for something, Dr. B writing a prescription, and Dr. C writing a prescription. And because they are standalone entities and we don't yet have that combined platform, you've got prescriptions that they don't sync well with each other. And there are doctors of pharmacology who you can take your prescriptions to, who are going to look and see, are you at risk based on the drug combination and the drug interaction. So it's super important, not just that you stay on top of one of your doctors, but that all of your doctors know what's going on, because the very thing that you can be given to save your life can put you at risk.
Absolutely.
Yeah.
And Natalie, thank you so much for bringing up that point. I mean, just a couple of days ago, I was complaining about that same thing.
Yeah. Yeah.
Because I have patients, they're referred in to me by their general doctor or whoever, and they come in and I don't know what they're on. Uh, and the question I always ask is, what are you on? And sometimes the patients don't remember because the names of the drugs are so crazy.
Yeah.
So many of them sound the same. So I say, well, do you have a prescription, or do you even bring them? So
Mm-hmm.
that's why that's such an important point, and which is why this show is also so important, because for your audience listening, to let them know that when you're going to see a doctor, for the first time, and maybe even a doctor that you see regularly, carry your medication with you, or
Yeah.
use recent set of prescriptions from whichever doctors.
It makes
Because
sense.
all medicines can be poison. You just need to give a high enough dose,
Right. Okay.
right?
Ooh, wow. Okay.
Oh yeah.
Okay.
Yeah. If you're supposed to take one tablet of something and you take 10, well, that's
Yeah.
poison.
Yeah. True. True.
So
Yeah.
all
True. True.
medications are poison, just not in that poisonous dose, hopefully.
Right. Right. Right.
So we have
Gotcha.
to acknowledge that, and we have to acknowledge that the dangers that we can do, as Natalie is saying, that we can actually harm patients. And the number one mandate of every doctor is to do no
Do
harm.
no harm.
Yeah.
Yeah.
Even if we don't do
Yeah.
anything for you, that's okay.
Yeah.
It's okay to do nothing, but to go and do harm, that's a no-no.
Yeah.
That's an absolute no.
Gotcha.
And this is why education is important, so that the patients know beforehand that when you're coming for that visit, you know, carry your medication. There's actually something called a brown bag autopsy. So the brown bag is where you put your medications in this bag, right? So you say, put
Mm.
all your medications in a bag and you just bring them.
Mm-hmm.
When you
Mm-hmm.
come, you put them all out, because there are many medications with all different kinds of names. And sometimes, because of the brand, you can have the same medication with a
Mm-hmm.
different brand name,
Mm-hmm.
but you think that it's two different drugs.
Mm-hmm.
Amen.
So you're
Oh, like I'm
overdosing on
on
that drug.
cataflam and diclofenac.
Right.
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 Exactly. So you think, oh, I'm taking cataflam. Oh yeah. Oh, but this other doctor gave me diclofenac for the same problem. So let me just take both of them because I'm still having pain, right? I'm still having pain. So I'm going to take the diclofenac and the cataflam. And next thing you know, your stomach's all eaten out and
Mm-hmm.
you're
Mm-hmm.
pooping out blood.
Right. Right.
That's
Right.
so
Wow.
Um,
scary. That is so scary
Yeah.
when you guys talk about that, because how many women or how many people are being affected by this? That's actually very scary.
well, a
And
Yeah.
lot.
and again, yeah, for patients to be proactive and have a little bag, go to the doctor, including the supplements that you are
Yep.
taking,
Absolutely.
everything. I think just
Yep.
get an idea like, but doc, you know what I'm taking? I said, no, I don't. I said, I know what was written on the last prescription that I gave you, but that
Exactly.
doesn't mean that's all you're taking. So then
Mm-hmm.
Exactly.
religiously, the first thing I'm going to ask you for is your medication. Second thing I'm going to ask you for is your blood pressure logbook. They know it's a routine because
Yep.
that's going to help
Mm.
Absolutely.
you in the long run.
Absolutely.
Okay. All right. Well, this is good.
Yes,
This
Miss
is good
Six.
stuff. Yeah. So let's talk about screening and early detection. So, what are the
Yes.
recommended screening tests that you suggest, Dr. Hoosang, for heart health in menopausal women? I know as I said, when I started with this high blood pressure, that was the first time that I went and did my nuclear stress test, and I did my echo, and I did all of those things. So I knew the heart was healthy, but it was the hormones that
Right.
were kicking off. So what do you suggest for women, whether they're perimenopausal because their estrogen is dropping, or whether they're in full-blown menopause? What should women be doing now to ensure that the heart is strong and healthy?
For sure. So I think that the first thing that we need to think about is timing. And when to screen is just as important as what to screen for. And I think that for most women, I think that once you start reaching 40, you should probably get screened, ensure that you've had because if you've been exercising or whatever, you might not have had a reason to go into the doctor before. But I think going in for a well visit, just get your blood pressure checked. Yeah. To make sure everything is okay. So the blood pressure is real easy. You just need a machine to measure it. You pop in the office, put it on your arm, boom, blood pressure. But other investigations will need to be done. We've spoken about cholesterol, so sure, a fasting cholesterol. We spoke about diabetes, so your sugar, your fasting sugar, something called your HbA1c, which is like an average of your sugar over a 3-month period, should be done. Then there are other things that you might also want to consider, like a CRP, which is a measure of your inflammation. So we think of atherosclerosis in most cases as just narrowing of a blood vessel, but it's a little bit more than that, because there's actually atherosclerosis is actually an inflammatory process, and there's a lot of inflammation that goes into it, which causes the endothelial dysfunction, which is why you need things like nitric oxide, which is one of the benefits of arginine. So you have all these things. So inflammation is a big part of it, and looking at inflammatory markers also can attenuate your risk. So if you have a high CRP, that means that your risk is higher, and you might want to consider earlier initiation of treatment. Once you factor in all the other things, would be important. An ECG would also be important, especially if if you're starting to develop higher blood pressure or whatever. That's important. Not everybody needs an echocardiogram necessarily, or a nuclear stress test, but that would depend. And those depend a lot on your symptoms primarily, to drive. Hi, Sandra. uh, your symptoms to determine what higher level of investigation will, because as Tana said, not just the blood tests are expensive, but a lot of these other tests are quite expensive. So a nuclear stress test is very expensive. I think starting with an ECG is usually a fair good baseline as a screening test.
Okay.
It's accessible. It's not so expensive. So I think those to start off with can be considered. And also, depending on your level of risk, you can look at things like your coronary calcium score. So coronary calcium score is a test where it's done using a CT scanner, and they can actually measure how much calcium is in your vessels. So if you go through in the scanner and they say, oh, your calcium score is 0, that's great, because if your calcium score is 0, it means that you're really low risk. Okay, and you probably don't need much done with you after that. If your calcium score is now high, then I think we need to look at that with a more discerning eye, and probably some pharmacological, traditional therapy may be required at that point in time.
So what is that test? The calcium one? What does that
The
involve?
calcium score. So it's a CT coronary calcium score. So it's a type of it's a CT. So it's using the same CT technology. Okay, you put them on the bed, you slide them into a machine, they get radiated, and a picture pops up on some screen somewhere. So what it does, so calcium is dense, right? So when you shoot an X-ray beam into it, you can actually see it. It pops up as a chunk, like a stone, almost. So you shoot this X-ray beam, and it looks like a little pebbles or in the actual vessels. And so what happens is that when you have atherosclerosis, which is a plaque that builds up usually as a result of buildup of cholesterol, over time, the plaque may become calcified.
Okay.
And this calcification in the plaque, there's usually in more severe disease, you'll have more calcification. So the coronary calcium scores, so when you do the test, they can actually see how much calcium is present in your coronary vessels. And based on that score, they can also tell you about level of risk. And if your calcium score is 0, then that's great. And it means that your risk of having heart disease or coronary artery disease is very low. So it's useful from what we call a negative predictive value. So it doesn't tell you necessarily that, oh, you have this or you have that, but it's very good at telling you that you don't have it, if that makes any sense.
Yeah, right. I have a question about the ECG.
Yeah.
Something that, like, I've had it done a couple of times based on, you're having a really bad pain somewhere.
Yep.
And you go, all right. So the ECG is something that, the the sticky pads are put on your body,
Yep.
and it tracks out your heart rate, your sinus rhythm, your heart rate variability, that kind of thing. But the thing that always confuses me is it's only reading what's happening to me while I'm hooked up to that machine.
Correct.
How does it then tell if you've got a risk factor?
Okay, so I think it's important that and that's an excellent question, Natalie. So thank you for that. I think it's important that when we do these tests that we understand exactly what to expect from it. And as you said, it's only telling you what's happening right there at that point in time. So if it can show you, so what do we expect from an ECG? So an ECG, as you said, is where they put all the little stickers and the wires that come from you on a piece of graph paper, prints out of the machine or on a screen. And really, it's just a very basic screening test. It gives us information on evidence of enlargement of the different chambers of your heart. So most commonly, hypertension being one of the more common risk factors can cause changes in the heart. It can cause thickening of the heart muscle, what we call left ventricular hypertrophy. So sometimes we can see that. And if there's a presence of left ventricular hypertrophy, that means that your risk is also increased. It looks at your heart rhythm. So as you mentioned, normal sinus rhythm, that's your regular rhythm. So it boom, 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 that's normal. But when the rhythm changes, which can sometimes occur, and there are many different irregularities of the heart rhythm. Probably the most common one is atrial fibrillation that we see in clinical practice. That puts you at increased risk of having things like stroke. So you can detect that because not everybody feels when that heart rhythm changes. Sometimes you do feel it when you feel the heart beating irregularly. But there's some people who the rhythm can change and they actually don't feel it. So it's good for screening for that. We can also tell sometimes, depending if you have had a heart attack already, it is also can be seen. But in terms of risk factors, well, risk factors are things that you can tell most of those even before you do any test, you know. If you're known to have high blood pressure or diabetes, well, suppose you have to test for diabetes and high cholesterol. So those would be the things that would tell you that you have risk factors and which would be more likely to prompt you to have an ECG. So ECG doesn't necessarily tell you your risk factors, even though you can see other things like the irregular heart rhythm, like atrial fibrillation. You can see left ventricular hypertrophy. Those do add to your increased risk. So you can think about it that way. But it can still be just a screen test because you can have left ventricular hypertrophy that does not show up on your ECG. So your heart can be thick, but you don't see it based on the criteria that you're using. Or you can have an irregular heart rhythm that's not there all the time because it can come and it can go. But at the time when you're doing the test, your heart can be perfectly normal. So in those cases, it would depend a lot on the clinical picture. What's the story? And which is always the biggest thing because, you know, a lot of patients come and they go and, okay, doc, I want to do the heart test. I said, well, there are
Which
multiple
one?
heart tests.
What?
All of them.
There's no the heart test. So
Right.
it depends. And like I
Yeah.
said earlier, a lot of my answers start off with it depends.
It depends.
So,
Yeah.
so what does the story sound like? And that's where we have to start. What is your story? And
Mm-hmm.
really, when patients come to my office, 99% of my information I get just from sitting down and having a conversation.
Right. Right. Right.
Even
Mark,
before I
you
put a
know,
hand on that patient, I already have an idea what's going on.
of what's going on. Oftentimes, one of the symptoms of menopause or perimenopause is heart palpitations, right? For me personally, this was a significant, before I started HRT, this was significant.
Yep.
But every time, because I wear my tracking device, I wear my ring, or I would, track using a fitness tracker or whatever, and my heart rate was normal. My heart rate wasn't elevated, but my heart feels like it's pounding.
Pounding, yep.
What's going on there? What's up with that heart palpitations that we experience?
I
What's
have no
really
idea.
happening? You have no idea. Okay, good.
No, and that's the honest truth.
Mysteries of menopause.
Because so we know that happens, right? So we know
Mhm.
that it happens. We know that it's pretty common in menopause for women to have palpitations. That is definitely not uncommon and it's seen in many, many women. Why does it happen? Well, we theorize that it has to do with the effects of estrogen and the effect on the electrical properties of the heart or whatever. But as you said, a lot of times when you actually look at the rhythm, you actually don't see anything change. Your heart rate may be the same. So oftentimes we do a lot of tests and the tests are negative. In other words, they don't show anything abnormal. So we're never really sure, but the patients clearly complain of symptoms and it's clearly related to the timing of the menopause. So we know it's the menopause causing it, but what is it doing exactly? We're not entirely sure why they get this heart pounding. I mean, maybe somebody smarter than I might know, but I personally I personally don't really know. You know, I know that it happens. Yeah, for sure, I know.
Okay.
And we do know that hormone replacement can resolve or at least alleviate a lot of those symptoms. And because drugs and regular medication that we give for palpitations aren't always very effective for those type of symptoms. And only when the patients do get hormone replacement do the symptoms go away.
Okay. Well, I think it's important though, as we talk about the heart palpitations, because on this episode we've heard so many women, that's the biggest thing. And then they go and they get their checks and they don't get to seem to get some answers. But at what point do you say, is it a heart attack? Is it heart palpitation?
Yes.
Do I need to be running to my doctor because at what point, I mean, what would you say to a woman who is going through menopause, she's having, but you say, oh, it's just heart palpitations, you'll be fine.
Oh,
But
it's
she's
just
really having a heart attack.
heartburn.
It's just
Oh,
heartburn.
it's
But
just
she's
that
really
ache
actually
in my
having
chest. Yeah.
yeah, but she's
That's
really actually having a heart attack. What do we say?
so that, Nikki, is a very good question. In fact, I would say that question is so good that it's actually two questions. So I'm going to divide it into the palpitation side of things and the heart attack kind of thing. So palpitations, most of the time when people are having palpitations, they're not having a heart attack, right? Most of the time. And the palpitations may mean that your heart rhythm has changed in some way. And it can change in a way that is not that significant. It's not normal, but not significantly abnormal to say, well, you're going to die. But sometimes it can be significant to say, well, you're at a higher risk of dying or you may die because of what's happening here. And again, it goes back to the story. So how often are you having this? How is it impacting your life? And then that will determine how much. So if you say, well, I feel my heart skip one beat once a week. Well, I'm not going to do anything for that because it's once a week. You feel like a thump, it goes away, nothing else happens. And that's probably not really going to affect your life. And there's a low risk of you dying from that. So I'm less likely to go on to do further investigations for that. But if you're now having palpitations, so if you're feeling it beating very hard or very fast, or if you have other associated symptoms, such as feeling that you're going to faint, you're feeling short of breath, or if you now start having chest pain, then, well, that's a different kettle of fish. And that sounds like a different animal. And I would be more likely to go on to do further investigations, such as an echocardiogram or ultrasound of the heart, or some kind of monitoring for your heart rhythm. Well, there's a test that we call the Holter monitor, which is kind of like an ECG that you wear around with you for 24 hours. So you come into my office, we put it on, you go home, you come back the next day, and then we look at what we've captured on that recording. In more recent times now, because as Natalie had mentioned, their wearables. So there's their rings, their watches, their device that you strap onto your chest. And these devices are actually getting to be pretty good. Because certain watches, you can actually print out a very simplified version of an ECG, which is very handy because a lot of times these symptoms are not there all the time. And as I mentioned, when you do the ECG, when you come to my office and I do the ECG, it can be normal, but that doesn't mean that you're normal. It just means that it's normal at this point in time, just right now. But, I do it now, you're not feeling anything, it's normal. Well, what does it mean? Probably nothing. Because as soon as you leave the office and you start having symptoms and, I've kind of missed that opportunity, so to speak. So the wearables are very useful now in today's day and age, because now when you feel it, you can now activate your device or to do an actual ECG tracing, which can be useful if you can now report that back to your doctor, because many of the devices it can be emailed to your doctor, which is what I have a lot of my patients do. They email me back the actual tracing that their device does, and then I can analyze it and I can give them feedback on that, which is why the feedback process is also very important. So what's your story? What's the feedback for that? And if there are any life-threatening irregular heart rhythms, then those will need to be addressed. So the second part of your question about heart attack, so it can be very difficult, because most people will think, oh, the classical chest pain as described in men is, a crushing central type of chest pain where they feel they can't breathe and they have excessive sweating and short of breath and so on. That classical pattern is in many women, they don't present very classically. So they don't present with that very classical crushing type of chest pain. And which is why there tends to be a kind of a gender bias, so to speak, in terms of diagnosing and treating coronary artery disease in women. Many women are not diagnosed or are diagnosed later than men. And there's a very clear gender bias in terms of coronary artery disease with men and women, because at the start of the show, you said, well, women don't think of themselves as having heart disease, and that's so true. That's so true. And not only do the women not think so, but sometimes the doctors don't think so, which is worse. So again, it goes back to the story, and things that you can look out for are atypical locations. So sometimes throat pain, jaw pain, neck pain, back pain. So instead of the chest pain, they feel it in other areas. And that can represent evidence of coronary artery disease or angina. Okay, angina is when your heart's not receiving enough blood and you get chest pain or discomfort as a result of that. Associated shortness of breath. So sometimes they don't actually have any pain, but they just get, they notice that when they do activities, they're walking at a certain distance, they get very short of breath to the point where they have to stop. A decrease in exercise tolerance. So if you're used to doing spinning, 5 days a week for 4 hours a day, and then you realize that you jump on the cycle and you can only do it for 5 minutes, well, something's wrong, right? And that can be a representation that you have coronary artery disease. So any change in your exercise tolerance, any undue shortness of breath, we all get short of breath depending on what activity it is, but it's about context and what is normal for you. Feeling to faint, excessive sweatiness for no reason. Those can be signs, but we also know menopause can also cause
Exactly.
a lot of things, and sometimes it's not so easy to differentiate. But what my recommendation would be is that if you're having significant symptoms, get it checked out. Get it checked out. Go to your general doctor first, and you go through him or her, or them, they. And that person will say, well, this is what I think is happening, and they may send you for tests themselves, or they may refer you on for further evaluation by a specialist, by somebody like myself, a cardiologist, or depending on what they think is wrong. So I think that if symptoms are significant, get it checked out, and then let that doctor decide, is this something significant or not? And then you should also decide whether you're okay with what was said.
What they've said.
Right.
Yeah, for
Because
sure.
sometimes you go and say, oh, it's nothing. And you say, well, it doesn't feel like nothing. Right?
Yeah.
So let me get a second opinion, which you are entitled to. Some doctors get very offended when they say, okay, well, I'm going to get a second opinion. Well, everybody's entitled to a second opinion. Okay. Even my patients, some of my patients say, well, I'm going to go seek a second opinion. I said, fine, you go ahead. What you're going to find, that's the same thing I did, but that's okay. That's okay.
Yeah.
So I'll see you back, but you get that second opinion, and you tell me how that goes, and I'm okay with that, because I'm not perfect. I'm just a guy doing a job. I just have a little bit of training, a little bit of experience in this area, and that's it. So my work, my assessment is not law. I'm not God.
Yeah.
So I want to see somebody else, I can't be offended.
No.
And I
Yeah.
don't. Yeah.
Appreciate that. Appreciate that immensely. I have a question about hormone replacement and the protectiveness. So we have our natural hormones, they are protective, they start to decline, our risk factors will trend up. When we go on hormone replacement and we start to try to stabilize or lessen the impact of those fluctuations, are we also making the physiological changes necessary in the body so that we are still as protected as we were before our hormones went weird? Am I making sense? Like,
Yeah.
if my
No, I get
okay,
you. I get you.
okay,
Yeah, yeah. So what you're saying is, does hormone therapy make your risk go back to the way you were before menopause?
yes,
I think that's the
yes,
question, right?
Mhm.
yes.
So the answer is no. Not
Oh,
quite.
okay.
Not quite. And again, as with most of my answers, it depends. So it depends on what you're giving, it depends on when you're giving it, and it depends on how you're giving it. Because you know what the thinking automatically would be, well, if these hormones are dropping, then well, just give them back. But the data suggests that we have to be very cautious with that approach, because by just giving hormone replacement therapy, you do increase your risk of having things like stroke and clotting, what we call thromboembolic disease, or clotting in the veins, which may break off and eventually go to your lungs. So there are risks associated with hormone replacement therapy. And it also depends on how you give it, because are you giving it orally or are you giving it transdermally?
Right.
I think there seems to be
Is
a
it
lot.
bioidentical? Is it synthetic? What's all
Right.
of
So,
those
so there's a
variations?
lot of other things that go into it, because it seems like the transdermal route is a little bit better than the oral route. I mean, there's a lot of controversy in this area, and there's still a lot of research, I'm definitely maybe not the expert in that part of the area in terms of replacement therapy, but it also depends on when you're giving it, because the recommendations, I think, are not really, you don't really give it for reducing your cardiovascular risk. And that's not something that we would do normally, because we know of these other risk factors that can pop up. But with some women, as you already said before, there is a role for hormone replacement therapy, and it really depends on the individual. And you have to determine, well, what is their risk of having stroke? What is their risk of having a clot in the legs, what we call DVT, versus the symptoms that they're having. And it's a risk benefit ratio that we try to calculate to determine what is the best alternative for you, and based on what the science is at the time, which changes every time you turn around. There's a different study showing you this and that.
It's true.
Which one is it? Is it a low dose estrogen with a small amount of progesterone, or is it just estrogen only? And a lot of those things are kind of controversial. But generally it's preferred if you're not on hormone replacement therapy for very long, in terms of long term, like over 60 and so on. You have to be very careful with those patients, because those are the patients who are, again, higher risk of having stroke and clots. So definitely early initiation in certain patients, certain women, I think tends to be the preference. But definitely we have to be careful that it's not a forever thing, and it's not necessarily for life.
Mhm.
Because as you do get older, the benefits of that might not be as great as we think. But the risks are definitely there.
Mhm. Yeah, no, I think my biggest takeaway from this as well is that, for women to really be an awareness of what is going on in their bodies. And if there's change or things that you're not happy with, you need to go and speak with your doctors and take your medications and let them know what you're taking. And to protect yourself in any way that you can, whether it is through HRT or it's not, if that's the route that you don't go. And we talked about, because I know we're running out of time, we talked about the different supplements Natalie had shared, diet, exercise, really getting in on fine tuning your body and your heart in this stage of your life of menopause, because changes are happening so much for women that they get scared and they get overwhelmed and they don't know what is happening to their body. And
Yeah,
sometimes some women just shut down. They don't want to
yeah,
they don't want to deal with it. They don't know how to deal with it. And as Tana
That's right.
said, you go to and you get this panel and everything is normal and you think, okay, I'm great, but you really are not great. So as we close off here, I would ask you, what is one piece of advice? I know this might be hard for you because you're full of so much good stuff, but what is one piece of advice that you would give every woman in their 40s and beyond regarding about heart health now during menopause?
Well, really, I mean, it's just adhere to basic rules, things that we have known to be true forever. Um, Diet, exercise, and really listen to your body. And when your body tells you something, and if you feel something's not right, get it checked.
Okay. Yeah. Awareness.
Yeah.
It is because it's happening and it is, as you said about it, what was scary to me was that, the women, becoming equal as far as with men with their heart
Yep.
disease and problems. I mean, a lot of women don't realize that in menopause, that it
mm-hmm.
affects your heart. I mean, we've talked about estrogen receptors in every part of our body.
Yep.
And
Absolutely.
I know for some women, they have done the HRT route because just to protect, not because of the hot flashes and all of that, they can deal with all of that, but to protect their heart, to protect their lungs, to protect what I call the big boys.
Bones.
Yeah, and the
Yeah.
bones. That's what I call the big boys, to really give yourself. So do your research, ladies. Speak to your doctors, and do what you
And if
feel
your
is
doctor
right.
shuts you down, and tells you it's all in your head, like some doctors
Mhm.
are still telling people,
Yep.
then you may want to go talk to another doctor because it's
Keep
not
going.
all in your head. Yeah.
Yep.
Yeah.
As
These
Dr.
are
Hoosang
these are
said,
very
get your
real
second
changes.
opinion. Get your second opinion, third opinion, fourth opinion, whatever it is
Yep.
you need
That'll do it. That'll do it.
until you can get the answer. So this has been great. I don't want to keep you much longer,
Yes.
Dr. Hoosang. Thank you so much for your time.
Thank
This has been
you. Thank you. Thank
amazing.
you. Thank you.
You're
Great
welcome.
Thank
stuff.
you. Thank you. Thank you.
Thank you guys for inviting me. It's been fun.
Yeah,
We should do this
Yay.
again.
it's been a good discussion. Thanks so much. Thanks so much for your contribution, Tana. I really appreciate that. And we look forward to the
Yeah.
next episode.
Yes. Awesome. Bye, everyone. Thank
All right.
All right.
you.
Have a good
Thank you
Thank you
one.
guys.
so
Bye,
much.
everybody.
Okay.
Have a good
Bye.
day
You
and be
too.
safe.
Bye.
Bye.